So, dear Professor Peacock and Professor Collins, dear colleagues, it's my pleasure to welcome you to my presentation about misdiagnosis of acute myocardial infarction, prevalence, patient and institution characteristics, and impact on mortality. As we are all aware, acute myocardial infarction is a major cause of death and disability worldwide. Despite current clinical practice after the introduction of the fourth universal definition of myocardial infarction, where there are multiple investigations available for the diagnosis of acute MI, such as ECG changes, serial measurement of cardiac troponins, and coronary imaging, some cases are still missing. Misdiagnosis of acute MI can have a detrimental impact and harm patients because withholding therapies and procedures such as rhythm monitoring, antiplatelet therapy, hydrostatin, and early revascularization may increase morbidity and mortality. However, to date, there is no sufficient data on the misdiagnosis of non-ST elevation myocardial infarction in the emergency department. Therefore, we aim to determine the prevalence of MIST and STEMI in the emergency department, the potential factors related to misdiagnosis, and to evaluate the impact of possible misdiagnosis on the patient prognosis. So for achieving this, we use the APACE study cohort, that is a prospective multicenter international study recruiting consecutive patients presenting to the emergency department with symptoms suggestive of acute MI. An adjudicated final diagnosis was performed by two independent cardiologists, applying the fourth universal definition of myocardial infarction and reviewing all the medical records available, such as patient history, physical examination, results of laboratory testing, ECG, and so on, regarding the patient from the time of presentation to the emergency department until the 90-day follow-up. We use high-sensitivity troponin for our study, in particular, the high-sensitivity cardiac troponin T, the Alexis by Roche. So from 8,220 potentially eligible patients, our final cohort was 7,678 patients, as we excluded patients with STEMI and patients with an unclear adjudicated diagnosis and at least one elevated high-sensitivity cardiac troponin T. In our final cohort, 1,363 patients had an adjudicated diagnosis of NSTEMI. So now let's move to the results. So this is the central graph of our study, an alluvial plot that illustrates on the left side the adjudicated diagnosis, so as I said before, performed by two independent cardiologists, and on the right side the clinical diagnosis, so the discharge diagnosis made by the hospitals. As you can see, the adjudicated as well as the clinical diagnosis are classified in 5 relevant groups. So NSTEMI in red, unstable angina in orange, cardiac but non-coronary chest pain in yellow, including diagnosis as Takotsubo cardiomyopathy, heart failure, and myocarditis, non-cardiac chest pain in blue, and unknown, unclear symptoms in green. So now following the red flows from the right side to the left side, what we can see and we found out was that 470 clinical and STEMI diagnoses were missed, so around the 35%. So therefore, we try to investigate the characteristics of this patient with clinical and STEMI misdiagnosis in order to explore how this patient differed from the others that were correctly identified in emergency department. Of course, I will not go through all of this, but what I can say the most relevant are the age. Our patients were older, 72 years old was the median age. More female, the 34% of our population were women, and with reduced renal function. And what we can say about the cardiac troponin that were used in the different institutions. So as you can see, all of the patients had a measurement of cardiac troponin with the clinically assay available, but as we expected, a large numbers of NSTEMI diagnoses were missed in the hospital that used the conventional one. Then we further classified our patient as either type 1 MI or type 2, and as you can see from our results, the misdiagnoses were around the 50% in the two groups. So this brought us to the questions, were these patients undertreated? And here are the results. So these are the following the procedures and the therapies that were carried out during and after the hospitalization. So as you can see, patients with clinical and STEMI misdiagnoses were massively less treated in terms of intervention, only the 38% at the coronary angiography, only the 13% at PCI, and only the 4% at coronary artery bypass graft. And the same about the discharge medication. Only the 24% at the dual antiplatelet therapy, and only the 64% at statin. So now to the survival analysis, the Kaplan-Meier curve shows that patients with clinical and STEMI misdiagnosis, so the red curve, had a higher all-cause mortality rate at 2-year follow-up in comparison with the blue one that represented patients that were correctly identified as an STEMI patient. So this most probably not only because these patients were undertreated, but also because they were sicker. So the alluvial plot showed you that the vast majority was re-adjudicated from an initial diagnosis of either unstable angina or cardiac but non-coronary chest pain. Our study has resolved the study some limitation. Although there was a very detailed patient characterization, there is always the risk of misclassifying a small number of patients regarding the adjudicated diagnosis. And as we excluded patients with terminal kidney failure, we cannot say anything about these groups. So to summarize, the prevalence of missed and STEMI in the emergency department was around 35%. Patients with clinical and STEMI misdiagnosis were mainly elderly, more women with reduced renal function, and particularly in institutions that use the conventional troponin assay. And as I said before, the misdiagnoses were more or less equally distributed in between the two groups, type 1 MI and type 2 MI. And also they had a considerable higher all-cause mortality rate. So this brings us to the conclusion that a bundle of measures, including, of course, measurement of high sensitivity cardiac troponin, is necessary to avoid misdiagnosis of acute MI. I would like to thank all of you for your attention, my entire team of the Cardiovascular Research Institute in Basel, and I will be happy to receive any question.
Great job, and we have plenty of time for questions, actually. Nicely done managing your time. Go ahead, there's a question in the back, actually.
Very nice data.
Yeah. Is that Nick?
So very, very nice data, and a suggestion, really.
Yes.
It's interesting that mites were to type 2s. To make a diagnosis of type, and the outcomes in type 2 marginal function are much worse. So it would be very interesting to just do a sensitivity analysis by removing the type 2s to see if we're missing type 1 events that we have evidence-based treatment and outcomes could be worse. Have you tried to disentangle that data set yet?
Not yet, but thank you for your suggestion. I will for sure do it.
If I go to 12, there are much more women misdiagnosed in non-STEMI than men. I think this is very, very important because there is a huge literature showing that there is less women included in trials.
Yes.
And I think this is maybe an explanation. Can you elaborate a little bit more around why there are more women misdiagnosed?
Well, I think that we used to think about myocardial infarction as a male disease, but this is actually not completely true. So yes, this is a good point. We should maybe include also more women in our studies to have also a big sample and see.
I think all of us, we have also maybe the responsibility to go outside of the cardiological area. Maybe we should put psychologists, sociologists, and many people around the table to try to understand. Because here, repeatedly, we have less ladies diagnosed, less ladies included in trials, and we need really to stop looking only on troponin, etc. There's probably something else that we can and may learn.
Thank you.
Probably one more question. Yeah. Is there, yeah, up front. Go ahead. Yeah, right there. So,
Alessandra, that was a wonderful presentation. Thank you very much. As Alex was saying, that is a very important topic that is coming up repeatedly about women not being represented in clinical trials. Did you look a little bit deeper into the differences between how they presented at the emergency room? Were women repeatedly giving maybe different symptoms? Maybe instead of chest pain, burning, for example. Was that looked at?
Yes, thank you very much for your question. Of course, I didn't have enough time to show you all of our results, but when we also explored the chest pain characteristics, actually you are right. The patient presented with, let's say, atypical chest pain, so the pain was less irradiated to shoulder and neck, and also the main accompanying symptom was dyspnea, so other characteristics of atypical chest pain. So this is also another point to better go through.
Thank you.
Great.